Hi guys, today we're going to do a little bit of work on the difference between factitious DID and regular DID. The reason I want to bring up the differences because factitious DID is nothing like real DID. There's similar symptoms, but there's a big difference. And the first thing I'm going to read is out of psychnetapa.org. Compare the clinical features of 18SS giving a diagnosis of factitious or malingering dissociative identity disorder with those of 18 matched SS who were given a diagnosis of genuine dissociative identity disorder. Taking from a sample of 129 consultations. Clinical features suggesting a factitious diagnosis or malingering, including having a score above 60 in the dissociative experience scale, which is the DES. Reporting dissociative symptoms inconsistent with the reporting on the DES, being able to tell a chronological life story and to sequence temporal events. Being able to express strong negative affect, bringing proof of a dissociative diagnosis to a consultation. So what they're saying is somebody that is factitious is going to make up stuff. They're going to try to bring in proof of something that they don't have. Another one is having told persons other than those close confidants about the alleged abuse or alleged dissociative diagnosis. So basically, for media attention, they will tell everybody but their real legit family or people that have known them for years. They're hiding it. Reporting alleged abuse that was inconsistent with the medical or psychiatric history or volunteering allegations of cult or ritual abuse. So basically, they're making stuff up, but it's not in their medical history or their psychiatric history, and that could be factitious. Telling of alleged abuse without occupying shame, guilt, or suffering. So basically, like me, I went through a stage of about 5 years where it's like, I don't have it. Yet here's my medical history, here's brain scans, blah, blah, blah. Also, not having symptoms of comorbid post-traumatic stress disorder and having obvious secondary gain in having a dissociative diagnosis through media or self-based proclaim. So what they're saying is usually, and that's where I had to go through lots of assessments, you have to have something stating that you have post-traumatic stress disorder to begin with to even start the diagnostic of getting assessed for DID. The trauma-related prospect initials that DID is related to a combination of factors that include chronic emotional neglect and emotional, physical, and/or sexual abuse from early childhood, insufficient integrative capacity, attachment disorder, and lack of affect regulation by caretakers. In this view, DID is thought to be at the far end of the spectrum of trauma-related psychiatric disorders, EI being a severe form of post-traumatic stress disorder. So they're saying the two are linked. Real DID and PTSD are linked. Some features of factitious dissociative identity states can be influenced by social cultural factors, ASA social media. That false positive cases of DID have evolved in a treatment setting and that some psychiatric patients imitate DID. However, they also note that there are differences between authenticity and imitated DID, and that there is no evidence that DID subconsciously be created by social cultural factors. Furthermore, even if DID symptoms can be created iatrogenetically or enacted, this does not mean that genuine trauma is related and could exist. So what they're saying is there could be trauma with somebody that it has a factitious DID. So basically, there could be something in there, but it's not DID. Real DID patients concentrate on functioning on daily life, commonly try to hide their pathology, and they have not sufficiently integrated yet. They have partial or complete amnesia, traumatic memories. Now, the other people usually try to base their trauma on social media based platforms. So to say, they're going to make up something traumatic to get attention seeking behavior. Real DID patients will not do that. Real patients have personal experiences and is bodily and emotionally affected by them. So you have internal issues. Most people that have DID have, and I'm going to get more into that when I read farther into this. Give me 1 second. So I'm going to read this. The prior hypothesis of the current study we are doing, important previously found psychophysiological and neurobiological differences between real and fake engaging in active kinds of physical defense in DID patients. And they say the page numbers 30 to 39 and 40 are upheld when controlling for fantasy proneness, suggestion, and instructed and motivated role playing, and the upheld physiological and neurobiological differences between real and fake DID patients, including higher sympathetic nervous system activation, higher heart rate, and systolic blood pressure jumps, and subcortical activity. The imagdalar, whatever that word is, and caudate nucleus. For real people with DID, hyperactivation of this brain stimuli will show. So what they're saying is, that's why I'm so pushy on the brain scan thing, is because people that are suffering from DID will have different activations in their brain when different alters are out, based on, like, if they're reading something traumatic, it will ring, it will show in a different part of the brain with each alter. With fake DID, if somebody's faking, they've done this with studies. If you can look it up, Colin Ross had college students pretend to have it, and it will show nothing. So that was interesting. So trauma-related MS effects with identity state. Trauma-related MS effects within both real and non-real, given on Table 3, show significant regionally specific increases and decreases in cerebral blood flow. When processing the trauma-related MS as compared to the neutral MS between the DID and both high and low fantasy-prone control groups. These findings are depicted in Figure 3 and 4. Trauma-related MS effects between identity states. Trauma-related MS effects between DIS are given in Table 4. Different patterns were found for real and non-real when processing the trauma-related MS. Between the DID and both high and low fantasy-prone control groups, these differential patterns are shown in Figures 5 and 6. The results indicate that for some areas, the perohippocampal gyrus in the comparison NIST/TIST, or the candidate nucleus in comparison to TIST/NIST. The difference in blood flow between patients and controls is larger than the difference between the DID identity states. That's interesting. Just wanted to bring that little bit of education in. Both are from the psychnet.apa, which is American Psychological Association.org. And the other is the NIH, National Library of Medicine, Harvard Review of Psychiatry. So you can find both that information that I just gave in there. And I hope you found this useful. Again, you're welcome to take this to your mental health care professional if it helps in any way. Loves. Bye.